So in addition to our speakers, Dr. White will join us for local therapy, and we have Dr. Pavan Reddy from University, who's a professor of internal medicine at the University of Kansas School of Medicine, Wichita. So we'll get started with our cases. This is a 58-year-old with ERPR positive, HER2 negative metastatic breast cancer, primarily bone disease, which developed 18 months after stopping adjuvant AI. She received first-line treatment with AI plus ribociclib with good disease control for 9 months. Now has progressive bone disease and 2 new pulmonary nodules. Tumor testing shows PIK3CA mutation and an ESR1 mutation. How would you approach treatment for this individual? You switch endocrine therapy and a CDK based on maintain or post-monarch. Go to a drug targeting PI3 kinase AKT pathway or elacestrant. And are there any other aspects of tissue or CTT DNA genomic testing that would be helpful? Like number of mutations, the type of ESR1 mutations, and other things. Kari, do you want to take a shot at that since
Sure, I'll jump in first.
Covered the trials in this space? Yes.
It's funny how often this question comes up.
Yeah.
So, I mean, first of all, I think ESR1 mutation and PI3 kinase mutations co-occurring in a patient is still a relatively rare population, maybe 10 to 15%, I think, are the estimates. So, but when it comes up, it's very hard. I think probably the most important thing I think about is how do I give endocrine therapy for the longest period of time to delay chemotherapy or more cytotoxic therapy, and thinking about a little bit like what would be the options that I want to try to get through for that patient in total, and then think about how I start sequencing them. So for this patient, doesn't meet the year for the Emerald study where we saw the most benefit from giving elacestrant after the patients that had the most benefit had a year of CDK4/6 inhibitor. But it's 9 months, and I think if this is low burden lung disease, it'd be very reasonable to give elacestrant, because I think even if the next set of scans showed progressive disease, I still would be able to get to a PI3 kinase inhibitor or capivasertib. That being said, I don't think it'd be wrong if the patient, in particular if the patient had symptoms, and I wanted maybe more of a response to do the capivasertib now.
Anyone would want to switch the CDK here and the endocrine backbone?
Yeah, this is, I agree. I mean, I don't know that there's really a right or wrong answer here, because, obviously the patient had extensive visceral disease. We would be thinking about something more aggressive. So with mainly bone disease and a couple new pulmonary nodules, there probably isn't necessarily a wrong answer, although I think many of us are not giving alpelisib just because of the toxicities. There are some data published that suggests that the co-occurrence of both PIK3CA and ESR1 together confers sort of a worse prognosis. And I think, ideally in the future we'll have hopefully a good oral SERD and an active and fairly well tolerated, PI3 kinase drug to be using together. So in the absence of that, I think, I completely agree with Kari. I think there's a number of ways you could do this. I have a feeling that if you give her fulvestrant plus abema, she's probably going to progress fairly quickly, because we gave her one of our best CDK4/6 inhibitors, and she only got 9 months. So I'm not, especially we went over the data today that suggests that BEMA is not providing much benefit, at least in the post-marnic, for those patients that had progressed on ribo. So I'm not so, excited about that. But again, I think you could use one of these others. I'd probably use fulvestrant plus capi. It would be not unreasonable to use elacestrant as well. Obviously, we didn't want to follow her closely.
Dr. Reddy, any other additional?
I think I echo. I'd go with fulvestrant and capi, given the 9-month duration. Unless someone has a poorly controlled diabetes, I would likely want to go with elacestrant.
I mean, the other aspect is Emerald patients did come in after fulvestrant, but once you give elacestrant, we don't know if fulvestrant backbone will work. Right now, that's the only backbone we have to work with our PI3 kinase AKT targeting drugs. So that does provide some limitation. Go ahead. Yes.
Can I ask whether diabetes would also be considered upfront before even considering these PI3 kinase inhibitors, given that these tumors are likely going to be highly glycolytic and ultrasensitive to insulin signaling, and I'm guessing that's not part of normal standard of care here. I just wonder what the opinions are.
I mean, I'll be curious what others are doing. I am starting to try to think about this more upfront as I'm thinking, if I notice a patient has a PI3 kinase mutation or AKT mutation, and they're on first-line CDK4/6 inhibitor, I'm starting to think about, should I be checking a hemoglobin A1C, thinking about working with their primary to maybe get metformin started, thinking that this may be their next line, rather than waiting till when I'm planning a change in therapy, because then you're trying to get the new medicine started and starting metformin at the same time. It's just much more difficult.
Yeah, and you don't have, if the hemoglobin A1C is up, you can't, and so I think that's a really good strategy. It's not something that we as oncologists think about, and depending on where you practice, almost your entire practice is probably overweight or obese, and so we would all like to do it, but in reality, that's a big burden, right, to think about trying to undertake for majority of our patients, and so we need good strategies to actually apply it to our clinical practice. And the patients need it, but it's.
I was just going to say,
time constraint.
I think the future is bright because we have these new generation of, allosteric PI3 kinase inhibitors that are coming through. I think Relay Pharmaceuticals is going to be starting their phase 3 soon. We have Loxo that has a couple different allosteric inhibitors. Certainly the inavolisib looked less problematic in terms of the development of hyperglycemia. And my early experience with that drug has been more favorable than I would say with the issues we had with alpelisib. So I think the future is bright for developing better drugs because this pathway is really important.
Yeah. And I've also had the most stringent A1C criteria. You have to be under 6, right? For the other two, you can get on with higher A1Cs, and that might simply be what we're seeing with hyperglycemia. Okay, so next case is 46-year-old premenopausal woman with left T3 and 0 grade 2 IDC, 5.5 centimeters, 3 negative sentinel lymph nodes. At surgery, 1 was noted to have ITCs. Has had a mastectomy, germline testing is negative, ER 100, PR 50, HER2 negative, Ki67 18%, so it's a premenopausal largest tumor. Would you order gene expression tests to aid adjuvant chemotherapy? These patients weren't quite represented in TAILOR-X, but we're doing it for node-positive women, so this is somewhere in between. What do you all do? Dr. Reddy, are you using gene expression tests in a T3 tumor?
I mean, it's node negative,
Yeah.
T3, but I think we're looking at the biology, and
Yeah.
I'm not sure if 5 millimeter change in the size really changes the whole science.
Science, yeah.
So yes, I would order an oncotype or a mammoprint on this.
I agree. I do as well,
Yeah.
recognizing that this cohort wasn't in TAILOR-X, but I think biology is what matters
Yeah.
here. And I think if they had a low recurrence score, I'd feel comfortable omitting chemotherapy.
Yeah.
I may think about ovarian suppression and an AI in that patient instead.
Yeah.
So.
So she does have a genomic testing. The score's at 21, so not as low as we would like, but not very high either. So is that in between range? Do you do chemo, OFS, or try to do both? These are the cases we struggle with the most.
I would just say, we figured this out for HER2 positive and triple negative breast cancer. What do? We no longer give chemotherapy blindly and say, well, I think we'll see what happens if you recur or not. I think we're moving that way in endocrine therapy. The Germans are well ahead of us here in terms of the approach that they've done, which is to give us very small window of neoadjuvant endocrine therapy and assess endocrine response. Now the problem is, we all know Ki67, it keeps coming up, and we don't trust the Ki67. But at those larger academic medical centers, and we certainly do it not uncommonly, my patients would like to know when they're going to take a drug for 5 years, is it actually working? And so we can kind of hem and haw. And it's what's interesting about the West German ADAPT group is when they looked, you can have patients that have the intermediate recurrence scores, and if they are an endocrine responder, they do just as well as patients who have a low recurrence score of 5, right? Because it's all about, is the drug working? And some of these patients are going to be endocrine unresponsive, and some of them will. Most of the time, we don't know. We just give the drug and say, I hope, and so we're not quite sure. Let's just give chemotherapy. We hem and haw. But I think that's the future. I hope we begin to move into this era where we actually can give the drug for a short period of time, assess response. And again, Ki-67 is a problem. I fully agree with it, but I think we're going to have better biomarkers in the future to help us individualize therapy.
So in this individual, if you had seen them before surgery, you would potentially get gene expression tests before surgery and try to do 2-4 weeks of endocrine therapy till they went to surgery if it was low and use that?
Yeah, we're not doing, and again, I want to be clear, I mean, we're not doing it in all patients, but we're having this discussion with a lot of patients.
Yeah.
So, we can clearly get an oncotype from the core. We wouldn't want to do it after we've given endocrine therapy because we don't know what that means. So, and then assess endocrine response. So she has a Ki-67 of 18%. If her Ki-67 was 3% at the time of after 2 weeks, I feel really confident that she has a highly endocrine sensitive tumor and that would be a good approach. If I repeat after 2 weeks and her Ki-67 is 40%, I'd be like, oh, let's treat you with systemic chemotherapy. I think you have an endocrine unresponsive. So again, we're not quite there, but I think that's my mind is the future.
Yes, yeah, it would be a lot more tailored than trying to make guesses.
I was going to say, and I actually don't know the answer to this, but RS-Clin is what I often go to here.
Yes,
I do actually not know if T3N0 would be allowed in RS-Clin, if you can put that in. But, right, it's a way to put together the patient's clinical features, so tumor size, grade, and then an age, and then their recurrence score, and think about that absolute benefit from chemotherapy. And then I use that to counsel patients,
Yeah.
because ultimately I think this is a decision they have to make with us, right? What is enough benefit from
Yeah,
chemotherapy?
you can do T3 on there because I just did this last week on an individual. And now the RS-Clin and node positive is also online. The JCO paper came out, that's online. So since we talked about RS-Clin, I had a similar situation. It was an older patient, closer to 70, but a T3 tumor. And oncotype score was 26 or 27, so just above 25. But between the risk of recurrence at 16% with endocrine therapy, just generically, versus RS-Clin, it was 47% with chemotherapy. It was grade 3 and other things too, so that's what really, nailed the decision for that individual patient to do it, so it's an important tool. This individual would have qualified for the NATALY study, so would you have that discussion, or is the genomic test result helping with that discussion? For NATALY, for T3s, you didn't need to have a high genomic risk.
So this is, again, where the Germans are thinking ahead. And I'm not, I'm no connection, although my relatives are, yeah. But, yeah, exactly. So what they're doing is they're taking some of these patients who are endocrine unresponsive after a short window of endocrine therapy, and they're randomizing them to chemotherapy versus a CDK4/6 inhibitor. So, so these are some of the questions that we run into in the clinic. I think I would certainly talk to her about this. Is at the end of the day, she's anatomically high risk.
And I think the 4-year update from ESMO from the NATALY study would suggest that even in these node negative T2, T3, it was a combined analysis, the absolute benefit was about the same, about 4%. So, I think that there's justification thinking about ribociclib, and again, it comes down to patient counseling and what they want to do.
Yes. Dr. Reddy?
I would talk to them about it, but, would I really push in this? Probably not, no.
Yeah.
And without overall survival benefit.
Yeah, I think that comes to are we treating, we've shifted to having the adjuvant CDK4/6 inhibitors, which has helped improve outcomes, but it is getting wider and wider in the population.
Yeah.
And do we need to be giving it to so many patients?
Yeah.
And I also know, the problem is follow-up is so short, right? So if we had the crystal ball and it's 6 years from now and we see a survival advantage, of course we'd give it, right?
Yeah.
But we're in that era, the era we don't quite know. So you have to have the discussion with the patient.
Yeah.
And some people will say, I want to be aggressive, and some people will say, no, we don't know what the long-term outcome will be, so.
I mean, in most studies, the AIs over tamoxifen did not show survival advantage, and it changed our standard of care. 5 years, now 10 years of AI therapy. So even if we don't see the survival advantage, I think these drugs make it into the adjuvant setting, and then they're there. We're probably over-treating a lot of patients.
And again, I think every patient will be a little bit different in how they approach it. But again, she's anatomically at higher risk, and so it's important, I think, here to look at the relative risk reduction, and then based on the relative risk reduction, you can calculate the absolute benefit.
And maybe one day we would have such tools for adjuvant CDK, like we have now, RSClin and things like that, that would be helpful. Julia, what about radiotherapy?
So I think this is one of those cases you would get a lot of debate amongst radiation oncologists. I will say she qualifies for the CTCG MA39 trial. So they do, with their amendment that expanded oncotype eligibility to 25 into T3N0, be a good spot for her. The problem with T3, I mean, for the most part, in the adjuvant setting, post-mastectomy radiation with regional nodal radiation really benefits node-positive patients. We do know that there's been a study, the EORTC study, 22922, looked specifically at those patients who had node-negative medial quadrants, because we make a big deal of always looking at the axilla, but we have to really acknowledge there's two draining systems on the breast. We've historically, as local regional therapists, just kind of ignored the medial one, but anatomically, it drains just as much as the axillary one. It's particularly medially. In the 22922 study, for the patients who were node-negative and medially located, the addition of regional nodal radiation did reduce local regional recurrences and distant metastases and improve breast-specific survival at 10 years, questionably at 15 years. But so that's the truth. So you've seen the most recent meta-analysis from the early breast cancer trialist group, the impact on 1 to 3 positive nodes. But you do see this benefit in node negative, and if you just dig down in that EBC-TCG data, it's all these EORTC 22922 patients. So this is a case that I would suggest that she go on, I would offer her MA39. I think that's the best place for us to figure that out. I personally do not treat T3N0s that are not medially located. I believe regional nodal radiation is for those who are positive. This is something that really varies. You name the institution, I'll tell you what they do. So it's really variable. But if she was medially located, I would go back, I would look at all her imaging. I'm hoping she would have some imaging up front where I could see her internal mammary nodes, talk to her about it. But that would be the only scenario where I would consider it's really the T3N0 is the medial location. If she was an upper outer quadrant, even with the ITCs, that's a baby T3. There's no way I would treat an upper outer quadrant. I mean, you can't convince me biologically if she was like, 4.9 versus 5.5, that cancer knows it's crossed a line. So that would be kind of my feelings. Medial quadrant, off of trial, I would consider it. Upper outer quadrant, for which more than 50% are, even with ITCs, I would not offer her regional nodal radiation post-mastectomy.
Do you see practices differ in the area that you practice in community
In terms
radiotherapy,
of
for radiotherapy for
absolutely,
T3 tumors?
yeah. Especially for T3 tumors.
Yes.
We're working on that.
Yes, so more patients are being offered radiation.
It depends on the radiation oncologist.
There you go. We're working on it.
So the next case is a 62-year-old with ER/PR positive, HER2 negative right breast cancer, pathologically T2N1, 3.5 centimeter grade 1 IDC, 1 out of 4 positive sentinel lymph nodes, no extracapsular extension, ER100, PR90, HER2 HC1 plus, Ki67 15%. She's had a lumpectomy with sentinel lymph node biopsy. Oncotype recurrence score is low. She's postmenopausal, so that was obtained. And how would you approach CDK4/6 recommendations? With low oncotype, chemotherapy hasn't been recommended for this individual. So this is one positive node with good biology is something that we see quite a bit. We're happy when that comes back. So, the discussion is, great news, you don't need chemotherapy, but can I talk to you about taking something else for 3 years?
So it doesn't meet Monarch data, right? Because it's not 4 more nodes. 1 to 3 without grade 3 or T3.
Yeah, but
Okay.
meets Natalie.
So Natalie.
Yep.
And in Natalie, 80% of patients had chemotherapy, 90%?
Something like that.
Yeah. I would probably discuss it and not recommend it.
Matt?
I would have given neoadjuvant endocrine therapy. Sorry. Again, if I know that she has a highly endocrine responsive tumor, that's enough. But otherwise, I agree. I mean, I think this particular patient is going to do probably very well with an aromatase inhibitor alone. But I would have the conversation with her because she meets the criteria. We have to have the conversation. And then I think we would look very carefully at the relative risk reductions, and we would talk about the duration of therapy, the side effects, and the absolute benefit. And I think many patients would probably say no. Some people would say, listen, if there's just a 1 or 2% benefit, I want to be aggressive. This is where, again, longer-term follow-up of these patients is so critical. So we really know what the actual delta is, because if the curves are continuing to separate, we may have a different idea. So for example, I just had this discussion about late recurrences. What if the CDK4/6 inhibitors reduce late recurrences? If they do, we'll obviously be thinking about more aggressively, but we just have no idea right now.
What if, somewhat similar situation, but it was a grade 2 cancer instead of grade 1 and had 2 positive lymph nodes? Ki67 was a little bit high, but the genomic score was still low. So you have a little bit more anatomical risk. But you're going to use the genomic score to kind of be the primary driver of the discussion. So the N1's N1 and number of positive nodes wouldn't change your recommendation. Dr. Reddy?
Actually, in this situation, I would, of course, discuss it. I'd probably lean towards her at least trying the, even without grade 2, I'm just talking about grade 1, just because of the node positive, especially where we're not doing axillary lymph node dissections. And I know here she had 1 out of 4, that's kind of reassuring, but if you have 1 out of 1, I tend to lean towards at least give it, with the threshold for stopping it or lowering the dose being fairly low.
Really low. Yeah, that's a good point, yes. What about local therapy?
So this is a patient that I would love to try to, and either with 1 or 2 nodes positive or grade 1 or grade 2, really try to get onto the MA39 trial, provided they haven't had neoadjuvant endocrine therapy. Because I really think these patients who are low genomic risk are patients we're going to find don't need the regional nodal radiation. That trial, the targeted accrual is about 2,300. I think we only have about 500 more cases to go on that trial. So hopefully that will close soon. And without that, then this is a patient I would treat with regional nodal radiation, not on that trial. I think for hormone, I think we all have different opinions on what happens by subtype with nodal radiation, but luminal cancers seem to respond to radiation. And so this is a patient I would treat with comprehensive regional nodal, so supraclav, undissected axilla, and internal mammary nodes along with the breast. But the good news is you can still get it done in about 15 or 16 treatments if you, after lumpectomy, if you're willing to simultaneously dose escalate the lumpectomy region with your radiation technology. Dr.
Brown, how about lifestyle modifications, other counseling if the patient was obese? And not really diabetic, but proactively treating the bad influence of obesity.
As a non-clinician, you mean? So there is strong evidence linking, the use of aromatase inhibitors in particular to weight gain and metabolic dysfunction. And I think what's left to determine is whether, that change in metabolic health that occurs post-treatment will actually influence disease recurrence. I feel like we're not quite there yet to know what the impact is and whether we should be prophylactically reducing the risk of metabolic syndrome, right? So in thinking about the anti-obesity medication, should we be thinking about prevention instead of anything else? And I think you spoke to the potential effects or roles of metformin and other anti-diabetics, but that's probably all I would say.
Don't you think that if patients, ultimately what we're doing is making patients live longer from a breast cancer standpoint, it really becomes critical to reduce their cardiovascular risk, because that becomes a problem then.
Yeah,
Yeah.
for overall survival, it's definitely an issue. And, as the preclinical data come out, like the study that I showed today, endocrine therapy resistance being associated with more glycolytic tumors means that as soon as you get hyperglycemia, hyperinsulinemia in these patients, that may be a consequence of their endocrine therapy, but also a cause of their resistance. You might be worsening the secondary or the recurrences and the outcomes in those patients.
It's probably worth studying in this kind of a setting, some of the novel agents. And now anymore, a lot of patients are just on it and you don't even know it. Like they're getting it from,
Hers.
yes, somewhere. You don't know what doses they're getting, but from somewhere. So the next case is a 55-year-old with ER/PR positive, HER2 negative, metastatic breast cancer, lung and bone disease, which developed 3 years after stopping adjuvant AI. Received first-line treatment with AI Palbo with good disease control for a year and a half, now has progressive bone disease and 3 new liver lesions. Primary tumor testing and ctDNA analysis shows no PIK3CA or ESR1 mutation. Liver biopsy confirms the disease to still be ER positive, but somewhat high proliferation rate. What would you offer as next line of therapy? She's had a year and a half of AI plus Palbo. Matt, you want to take that? You can't send this one to Germany, so they've already had the trial for endocrine therapy.
What I would do is, if the patient's able, definitely put the patient on a clinical trial. Yeah. Now is the perfect time to put the patient on a clinical trial. Don't wait until they have 6 months to live. Now is the time to put them on a clinical trial. But if we think a little bit about some of the clinical trials that are ongoing, I think what we're going to see is that, based on EMBER and some of these others, that combination therapy is probably moving towards, the standard. So I like the idea, based on the post-Monarch, that demonstrated that, there was a larger benefit of abema in patients that had progressed on Palbo. The fulvestrant plus abema or fulvestrant plus ribo would be a good option. I find it hard to put patients on fulvestrant in this situation as single agent, with the median PFS of about 2 months or 3 months. So I think fulvestrant plus everolimus is a very good choice. Capecitabine, probably not TDXD quite yet, given the fact that the patient doesn't appear to have sort of visceral crisis.
Yeah, to me, that's what I'd want to reiterate. I think the patient should have another line of endocrine therapy and not go on to chemotherapy or a TDXD here. I think 2 or 4 would be reasonable. Everolimus, I've had some really good success with it. It's not always the easiest medicine to take, and so, I think it helps with doing the Dex mouthwash and things like that, but, side effects are important to consider too.
Dr. Reddy, using CDK after CDK?
I probably would, yes, either one of those would be 2 or 4, but I probably would lean towards fulvestrant and everolimus, and then go to the next line, just because 18 months, it's the average. It's so probably would want to switch to everolimus.
This is a 62-year-old with a T2 and 0 hormone-positive breast cancer, low-risk genomic assay result with the recurrence score of 22. Endocrine therapy with AI started. The patient has a BMI of 42. No known diagnosis of diabetes. Is the high BMI a concern with AI versus tamoxifen? We saw some of this data, and then that kind of died out a little bit. But for a while, we were worrying about it, and what else? Like, do you monitor estrogen levels with an ultrasensitive assay in this really overweight women when you give them an AI? Do you worry about it? Matt, any thoughts?
So we just published on this. So we had a study that we did in our last cycle. And so this was based on, we did a secondary analysis of the MA27 clinical trial. MA27 patients were randomized to either anastrozole or exemestane. And as you recall, there was no difference in the adjuvant setting between these 2 drugs. But what we did do was we had a secondary analysis where we had baseline and 6-month blood work. And so we used a highly sensitive E1, E2 assay. And we found if you didn't suppress your estrogen levels, you had a higher risk of recurrence. So we said, well, gee, that's interesting. So what we then did is we did a prospective clinical trial where we took patients who were on an anastrozole in the adjuvant setting, and using that cutoff that we said, that we found in that ultrasensitive assay, we just asked the question of, knowing that that cutoff was associated with worse outcomes, how often do you not suppress with anastrozole? It's about 25 to 30% of patients. We then actually did this. We actually went and used a 10-fold higher dose of anastrozole. We went up to 10 milligrams a day. It's been studied in the metastatic setting. It's safe. And what we found was we actually were able to suppress in most. But we also then followed patients. We put them on letrozole and found that they suppressed as well. So, you know, the question that comes up here is, this is all sort of circling around without level 1 data. But we're seeing more and more of this, and that is that we're probably not suppressing estrogen levels completely. It seems like in a number of studies it's associated with worse outcomes. When you do large studies of a gabillion patients, you see no differences, but yet there are probably subsets where they are higher risk. So I think it is a concern. And so I would want to have this patient, I'd probably treat her with letrozole. Will that lead to a better outcome? I don't know. You could check her estrogen levels, certainly have her see a dietitian. I think this is a patient where you really want to be aggressive with addressing her obesity and her BMI. And the metabolic syndrome workup, I completely agree with that. And with regard to the latter one, I'm not an endocrinologist, so I would refer the patient. I'm not at the point where I'm prescribing them on my own. I would send her to somebody. So,
Kristy?
Well, I've always wondered why we didn't weight dose our endocrine therapy. And I think your comment maybe is a testament to why there might be needs for that. From a biological point of view, we know that aromatase is expressed in the fat. The more adipose tissue, the more aromatase. So it makes sense to dose based on weight to some extent. But this also extends to chemotherapy, where it can be sequestered in the fat and it can be metabolized in the fat and inactivated. So, and I think in that case, there's been an acceptance that it's okay to dose, increase dose based on weight. So that was kind of what I was wondering with regards to endocrine therapy.
Maybe I'll add to that. I mean, there's also some interesting studies coming out now with low-dose tamoxifen. So in some ways, we could think about escalating, but also other patients that we could give lower doses to that have very endocrine-sensitive disease and don't need as high of a dose and might be better tolerated.
Would you consider a switch approach like tamoxifen for first couple of years till maybe you can get, hopefully make some positive impact on?
My clinical answer is I would not let it influence my recommendation.
Yeah.
So if they're high enough risk that I'd be recommending an AI, I would give an AI.
Yeah.
that's the same with me, and I'd probably use the most potent, which would be letrozole. I don't have any data that obese women that letrozole better than anastrozole, just some anecdotal that we're not probably completely suppressing in a subset. But this is something that deserves more study. It really does. And I think as we, I'll just make my plug, this is why there's a National Institute of Health. Right? Because these answers cannot be, we cannot answer these questions through industry. And industry is so critical. We have to be developing new drugs. But once they're approved, we have to figure out how best to study them. And for the drugs that are off patent, we can't do that otherwise. So,
So if
I
you
agree
agree,
from a clinical
make sure
standpoint.
you're advocating.
exactly.
Yeah, I would not change. I would start with an AI.
Yeah.
The concern with tamoxifen in someone like this is you worry about DVT risk. Are we going to put her at a higher risk given the high BMI? If she's not had a hysterectomy, are we increasing uterine cancer risk given the
With
obesity
weight, it's already
correlation?
there, yeah.
So, practice, you'll stay with an AI.
Yeah.
Start with an AI. And of course, we, at least where I practice in Wichita, we have a obesity clinic. So I have that luxury of referring these patients where they have a full gamut, including GLP-1 inhibitors for obesity.
And thinking about liver toxicities as well, right, of tamoxifen versus AIs.
Yeah. Yeah, they're more likely to have fatty liver and other things with the obesity. Okay, let's see. There. So in the same, spirit, if you have a newly diagnosed metastatic breast cancer patient that fit the criteria of the triplet Inavo, Palbo, fulvestrant, and you started that patient on it, and, they met the criteria for A1C, but their BMI is high. With the hopes of keeping them on the therapy, would you do any proactive management? Do you put these patients on prophylactic metformin up front and not wait for them to get hyperglycemic or any other approach?
I'll just go probably more from experience with Cappy and alpelisib, just because that's where we have more experience. I don't think I was as good at this as I could have been, right? I think that, as we were submitting a prior authorization for alpelisib or whatever it is, I could have been starting patients on metformin.
Yeah.
I think that it is, the 6 is pretty strict, and I think we are many times going to be pushing towards maybe like 6 or 6.5 in obese patients. I do think it'd be really good as you're sending off that prior authorization, start some metformin. You only need a week or two of lead-in, and we've seen some benefit, at least in studies with alpelisib.
Yeah. And metformin does cause diarrhea, so once you already have drugs that cause diarrhea, then adding metformin is a problem. So if you can get them used to it and dose built up. So that's a good strategy to think about. I would acknowledge I haven't been that good. Like once it happens, then we're all over it. But like before it happens, then.
Yeah, it'd be nice not to have to deal with it.
Yes. So I think it would be something for us to think about in our beacon plans and stuff, like, how we have all those alerts and things about you should consider do this, that, and the other. If the patient is overweight, consider interventions to control their blood sugar up front before they develop hyperglycemia.
I've had a couple of, with alpelisib experiences where now I routinely have them see an endocrinologist before they start a PI3 kinase inhibitor. We do that for other drugs. Ocular toxicity, you have them see an ophthalmologist, FDA mandated. The situation where they end up in the ER with a sugar of 600, I really want to avoid that.
I think some of the challenges is access to endocrine clinic, which a lot of us have struggles with, and even at academic places. The wait times are 3 months, 6 months, a lot longer. So even simple access to, dietitians and all of those things in terms of controlling the carbs would be helpful for many of our patients.
And I think the comment that Kari made is just having the patient just be, if you don't start it up front, or if you do one or the other, but have the patient ready to go. You will be starting metformin. We're going to watch it carefully. I just started a patient on inavolisib just recently, and it's that creep 1 week, 2 week, 3 weeks, and it's not out of control, but it's definitely up. She needs metformin, and so now we're starting her on it. So just have to be prepared. I think with alpelisib, it was a different drug, just much more difficult to give. And so I think what we saw from the inavolisib data, it looks like the rate of early termination is much lower. So that's reassuring. So we'll just have to see in our practice. It's one thing in a clinical trial, but it's another thing in our practice. So.
Well, there was the data that I showed where it is clearly an early side effect. And so the being prepared, maybe being preventative. And then once you get it controlled, people do quite well.
Exactly.
So being on top of it matters.
So Julia, can you comment, you alluded to a little bit in terms of weight and obesity and breast size and radiation and those types of decisions. Yes.
So I started my practice in Medical College, Wisconsin, where we developed a method of doing radiation simply out of necessity for very large-breasted women. And so it's called prone breast radiation, and so we've adopted it throughout KU. But when we looked at our initial population in Wisconsin a long time ago now, our average BMIs were about 36 to 38. Highest BMI I think was 56 in the population. And when we actually went through and looked then what were the risk factors for local regional recurrence, tumor size, histology, the only thing that mattered was BMI. So I think it's something we forget, that this does not just affect distant recurrence. That and obviously this was a select population of very large of women with a very large body habitus. So we do take that into account. if you're a large woman, you actually are at higher risk. What we found in those populations is women with a high BMI, we can control the radiation dermatitis better by using the prone. This has now been shown in a recent randomized trial out of the Netherlands. We can reduce the dermatitis because they're at higher risk for dermatitis. In our own data, we did not have rates of grade 3, we're as low in our high BMIs or low BMI. But these women still are at risk for having more pain long-term after their local regional treatments. And again, looking at every other factor out of there, it really came down to, I guess, a large, our average breast CC was, I think it was like 2,400, these were large people, 2,400 cc's, so 2-liter breasts, as I say, and about a really high BMI. So I think it has implications for when you do radiation. You have to have a knowledge of how to try to minimize their acute toxicity. There's good now phase 3 data showing if you know how to do prone and you can do it, it's technically a little bit more difficult, but once you get it down, it is helpful. If your institutions are not doing it, we're happy always to talk to you about first steps in getting it going. But to keep in mind that these women are at higher risk for acute radiation toxicity, and if the radiation is not managed well, minimizing dose heterogeneity, the likelihood that they're going to get a good cosmetic result goes down, and that I feel bad about.
Okay, our last case, 49-year-old premenopausal woman with a T2, 3.8 centimeter, N2, 4 positive lymph nodes, left grade 2 IDC, ERPR positive, HER2 negative, has undergone a mastectomy and axillary lymph node dissection. Germline testing shows a BRCA2 mutation. Has received adjuvant ACT. Menstrual cycle stopped during chemotherapy, and right post-chemotherapy, E2 FSH are in postmenopausal range. Adjuvant AI has been started. How do you monitor for ovarian function recovery in this person? What tests do you use? At what frequency? How long would you monitor it to be assured that the individual is indeed permanently postmenopausal?
Oh, good question here too.
Yes. So,
Definitely would monitor,
Yes.
at least for a year.
Yeah.
Probably even a little bit beyond a year. I've
Yeah.
had people recover their premenopausal status even up to 2 years.
2 years.
And we do the highly sensitive estradiol assay now because there's some cross-reaction with aromatase inhibitors if you use the standardized AI assay, or I don't know, at least at our institution we did, and we would have some that were falsely positive or falsely high. And probably about every 3 months.
Out of curiosity, did she get an adjuvant PARP inhibitor?
I was curious.
We're going to ask that. Yes.
All right, okay.
Yes.
Well, and I raised the question of whether PARP inhibitors affect ovarian function. Does anybody know? I don't know that answer.
Yeah. I mean, it can be given in premenopausal women.
Sure,
Yes.
sure,
yeah.
but whether it has a,
Has a-
but,
has
you know, one thing we do know is that these patients who are treated with adjuvant hormonal therapy, either in the adjuvant or metastatic setting, and have a BRCA2 mutation, these tumors tend to be a bit more endocrine resistant. So I think doing everything you can to make sure that the patient is getting optimal endocrine therapy is important.
Yeah.
Yeah, to be honest, I probably would start this patient on ovarian suppression to be cautious rather than just an AI alone. If they said they didn't want it, fair, but then it'd be monitoring every 3 months.
Because you can only monitor once every, I mean, you're not going to check it every week or every other week, and so if they have intermittent recovery, you may miss it. You know, this is a patient who would be eligible for both of the approved CDK4/6 inhibitors. You know, does the BRCA mutation status influence your choice? Anything else influences your choice besides the duration and toxicities?
So I would probably pick the PARP inhibitor over a CDK4/6 inhibitor here. And then I know there's some debate about then do you sequence to the CDK4/6 inhibitor afterwards. I think we have no data for that. So I would probably give a year of adjuvant olaparib.
Yeah, so you do a year of olaparib and then have a discussion about CDK. The CDK trials allowed patients to come in up to 1 year. And then there's the debate between which one of the two that you would go with, 2 versus 3 years, and different toxicity. Also depends on some of these young women, if they cannot tolerate an AI, then if you switch to tamoxifen, then that kind of dictates the decision.
Yeah, that makes much sense.
Yeah.
1 or 2 years
Yep.
Yeah, so that's why I was asking about tests, like, would you do an AMH at some point to not now keep worrying about every 3 month, 2 month, or whatever, E2FSH, which AMH is a lot more reliable for telling you who's right at menopause. But you do see AMH drop in almost everybody with chemotherapy, so it will drop, so we just don't know the trajectory.
And I think one thing about these patients is that we know that, that menarche is coming, menopause, is later and later. So the question is now in 2025, even if you're 49, usually in the past we would say, oh, don't worry about this patient because, they're age 49, we'll push them into menopause. But is that the case in 2025 with, all the issues that we know? And so I think careful monitoring would be important here.
Would you do an AMH or any other test besides an ultrasensitive E2?
At this point, I'm not sure I would, but this is an area that really needs to be studied carefully.
Yeah. How about radiotherapy?
Well, this is a patient would definitely get regional nodal radiation. I think there isn't a lot of variation on this. Obviously, we tend to try, in a case like this, heading to olaparib, we'd like to do the radiation therapy before that gets started, and generally that's how it's sequenced. I think with the shorter courses of radiation therapy, again, this patient could get 16 fractions. It helps to get them onto their adjuvant systemic therapy sooner.
And I know we've combined some of our targeted drugs with radiation and felt okay with it, but PARP inhibitors are one of those drugs we can't, at least not at full doses at all.
Yeah, we're seeing additional data in that regard.
Yeah, so.
I just, at this age group, it becomes harder when they're below 40. But, I start with it makes me nervous to put them on an AI without knowing for sure that we're doing the right thing. So I have counseled them use GnRH agonist for a few months and then for a surgical oophorectomy.
And especially with germline BRCA2,
Yeah.
but yes.
Mutation,
Because
even without
this
the
person's going to be on endocrine therapy for 10 years, so you're not going to.
that way I think you sleep better.
But I like what you said, I do similarly, a few months, see how they
Just to see how
tolerate
they
it.
tolerate it.
Yeah.
Because it is really hard if you remove the ovaries, and it's very difficult for somebody, Otherwise
So
you
even
at
if this
least go to
individual
trauma.
didn't have a germline BRCA mutation, but given the clinical scenario, high-risk disease, need for 10 years of endocrine therapy, that seems like a good approach that's more foolproof. Okay, that was our last case, and I want to thank all our faculty for great talks and a wonderful discussion and for sharing their insights with us.